the big difference, average of 81%. That means to us, infection control, that our healthcare providers wants to protect themselves most of the time, but not the patient. So again, this is an opportunity for quality improvement. How about compliance to hand hygiene after handling body fluids, after touching environment or objects involved in patient care? The average was 86%. Then we go to the wearing of the gloves. It's a very good trend. In the beginning, when we started the observation, you will see that the compliance was very low, only above 20%. Then, at the 4th month, it has improved to more than 60%, averaging 52%. So this just show that people think wearing gloves is an alternative to hand hygiene, which is not correct. Again, a time or an opportunity for quality improvement. What about after removing gloves? So you can see the trend that healthcare providers comply higher than before wearing the gloves. It averaged 84%. Overall, the average of our hand hygiene compliance was 70%. So if you benchmark it against the international compliance rate, we are not really that bad, but still there is a room for improvement. What did we do with the result? Did we just file it in our cabinet? No. What we did was we gave back the results to all the individual units that are concerned, and we used this result for educating our healthcare providers. It was also used in various presentations, in committee meetings, to tell them the status of our hand hygiene compliance, and in various lectures on hand hygiene update. The senior management was also informed through a quarterly report, and the patient committee actually decided that this report should be done on a quarterly basis and to report any unit that does not perform ongoing observation every month.
2 minutes.
In conclusion, we have noticed that monitoring has a desirable effect on hand hygiene compliance. It changed the behavior of our healthcare workers. It has a ripple effect. The spread of information was achieved, and in addition to that, because as I said, this is just part and parcel of the whole campaign, we will be having to sustain the change, a hand hygiene campaign scheduled on the 4th week of March 2009, and you are all cordially invited. So thank you.
To get your accredited CME certificate hours approved by Saudi Commission for Health Specialties, please follow the instructions. First, get Promed TV prepaid card from the outlet. Second, sign up at www.pro-med.tv and enter your PIN code and serial number, which is written add Promet TV prepaid card. Third, watch the existing lecture on Promet TV channel and answer the lecture questions seen on Promet TV screen. 4. Send your answers by SMS using your registered mobile or through Promet TV website. 5th, print your Saudi Commission for Health Specialties accredited CME certificate from Promet TV website.
I'll go into the certain facts, certain definitions, factors affecting the risk of infection, prevention of the exposure, pre-exposure risk assessment, and pre- and post-exposure management, and what's the key message of this lecture. Before 1980, healthcare worker exposure to blood and body fluids was not much of issue, and all of us remember this date that was before AIDS. In late 1980, CDC introduced universal precaution to protect healthcare workers from blood-borne pathogens. The first case of HIV transmission from patient to healthcare worker was reported in 1986. December 6, 1991, Occupational Safety Health Administration published its rule, which is occupational exposure to blood-borne pathogen, to further protect healthcare workers. It was estimated that between 600,000 to 800,000 needle stick injury occur annually that involve contaminated needles among United States healthcare workers. 2% of these are likely to be contaminated with HIV. 52% of 2,410 healthcare workers reported at least one prior percutaneous exposure, and half ER physicians reported at least one occupational blood exposure in one survey that was conducted between 1995 to 1997. During 1993, an estimated of 1,450 United States workers became infected with hepatitis B virus through exposure, and 100 to 200 healthcare workers died annually secondary to hepatitis B virus infection. Most infected healthcare workers could not recall an overt percutaneous injury, although in some studies up to 1/3 of infected healthcare workers recall caring for a patient who is hepatitis surface antigen positive. Hepatitis B can be demonstrated to survive in direct blood at a room temperature on environmental surface for at least 1 week, and for hepatitis C for up to 16 hours. Very weak HIV virus died quickly. 57 cases of documented occupational HIV and 139 cases of possible occupational HIV, and that was quoted from CDC, the distribution of already mentioned cases. So, already mentioned by Dr. Kauthar is the healthcare personnel. They are persons or employees, students, contractors, attending clinician, public safety workers or volunteers whose activities involve contact with patient or with body fluids and blood from patient in a healthcare. So what is the occupational exposure? It could be defined as anticipated skin, eye, mucous membrane, or parenteral contact with the blood or other potentially infectious material that may result from performance of employees' duties. Bloodborne pathogenic microorganisms that are present in the human blood and can cause disease. Just more than 30 organisms can be involved into healthcare worker, but what we are concerned about is 3 viruses, hepatitis B, C, and HIV. How we can prevent the exposure? In order to prevent it, we need to know the epidemiology. Who is the most concerned people, where it happened, when it happened, and why it happened. So this is our experience in the Dammam Central Hospital since 1416 to 1429. The most groups involved here is the nurses, and followed by surgeons. This is our most involved group, and followed by technician. So this is the CDC, it was quoted here, more or less the same. Nurses is the most group involved, it grows 44%, physician 28%. So where it happened? In our experience, most likely to be happen in ER. And why is that? We will mention it later. OR, and then surgical ward. This is completely different from reported in CDC, where it's most likely in the medical and surgical ward, and then intensive care unit. See the ER, it's only 8%. When do needle stick happen? 70% happen after use of and disposable and before disposable. So in order to prevent it, why it happen? I said, why it happen? When we are discussing this with the ER, it is a crowded place, and the sharp container sometimes in the middle, it's not near to the patient. And if we ask the surgeon, sometimes they will come with needle stick injury because the abbreviation of sleep. And few hours or most of the hours till the second day, they are in duty. And this is the most probable causes that could lead to needle stick injury. So we need to prevent it, to go with standard precaution. And already we heard a lot about hand washing, which is very important. How about the engineering? If there is any intervention with the patient, you have to go with the sharp container to put it. Not like this one, and I don't know what is the pointer. And do not overfill sharp containers. If, like in our ER, it's a big place, you take sharp container with you near to the place. Don't put it in a tray, like what happens sometimes, and then after you will finish, go to the large sharp container to put it. This will create a lot of a problem. And never recap, bend, or break needles. Dispose of the entire unit together. There is a lot of engineering control devices with safety features. Some hospitals, they have it. This is self-sheathing needle device, the first picture, and retractable needle device, and on devices. This is before retraction, and this is after retraction. So, certain practice, we need to change it in our daily practice. Like this one, rebend. We have a lot of cases like this. So, either to do scope method or to put it in the sharp container. Save yourself. If you are in the OR and there is a lot of instruments you have, and instead if you get needle injury, just put it in the head of the patient, or somebody else will take it. Instead that you will injure yourself or you will injure her. And this is another needle held loosely, because if it is rigid, it will stick to your hand and it will create a problem for you. And in dental clinic, see the practice by tissue, by fingers. Why not to do it like this, which is a correct way, by retractable? And recap needle. This is different instruments in order to recap or remove it. I don't know which hospital they have it. This is recap needle, anesthetic needle. That could be like this one. And this is another method, which is American needles. They call it the needles that be recapped. And this is autoclave. This is reusable. This is the one. They put it and they remove it. So, in non-sharp biological waste, also it's very important to be leak-proof, labeled with biohazard, and closable. Already mentioned in detail, Dr. Kauthar, that from these hepatitis B, C, and HIV, the most important preventable disease is hepatitis B, and vaccination is mandatory. In America, 12,000 hepatitis B infection occurred in 1985, and it was dropped to 500 in 1997. And the rest of this one already mentioned by Dr. Kauthar and the definition of non-responder. So education is the most important one. And you go with it every time. When? And during orientation, annually, and on as needed. And don't be depressed. It is a long way to go with it. Don't be surprised by the end, and you will find a lot of things that you have already mentioned it was not correct. And you need to monitor yourself. And by analyzing the data on a routine basis, a problems area, either due to a product or behaviors, can be detected quickly and correction institute. This is the Dammam Central Hospital for the last 13 years. See here how they much reported. In 14-16, we have only 2 patients. And here, it increases gradually, sometimes up and down. Here, it's 72 in this year. And we need to ask ourselves, why is that? In this area, there is a lot of nurses coming also. And they are new, which could be in one part that to be effective. And to monitor ourselves, we need to sharp exposure rate. We need to calculate it and establish system for identification of sharp exposure in the hospital. How you calculate this one? Number of sharp exposure in a year over number of patient days in that year multiplied by 100. And this is our hospital. This one for the last, I calculated only for the 29. This is per month, Muharram, how many exposure we get. Then by the end, we will calculate it. And then we will calculate patient days, which is very important. We will just divide and by 100. We will get 0.1 here. And next year you will see and you will monitor yourself. Are you going down or up? So what factors affecting the risk of infection? It is pathogen involved, Hep B, C, or HIV. Type of exposure, percutaneous, mucus, intact skin, non-intact skin, amount of blood involved in the exposure, small amount, large amount, and how is the patient condition like HIV? Is it late asymptomatic or AIDS patient? What is our goals in management of exposure? It's to prevent the transmission, avoid unnecessary post-exposure prophylaxis, and minimize toxicity, provide information, and determine whether transmission has occurred. If needle-stick injury happen like this one, so you need to wash exposed area by soap and water. This is the first aid. Flush exposed mucous membrane with water, and flush exposed eyes with water or saline solution. Do not apply cosmetic agent or inject antiseptic or disinfectant into the wound. You need to report the exposure. It's very important. And identification for donor and recipient, and to be confidential. And unfortunately, significant proportion of percutaneous injury are not reported to hospital surveillance system, and that was range from 5 to 60%, and this could be decreased by education. In one study that was published in the New England Journal of Medicine, June 28, 2007, they surveyed surgeons in a training at 17 medical centers about previous needle-stick injury, to keep in consideration high-risk patients for Hep B, C, and HIV. What they see? There was 699 responders, and of these, 83 they get needle-stick injury. See by progress of the years. By the final year, 99% of residents had needle-stick injury, and 51 of them they didn't report it. Why is that? They said lack of time, in 42%. So in conclusion, for that survey, needle-stick injury are common among surgeons in training and are often not reported. Improved prevention and reporting strategy are needed to increase occupational safety for surgical providers. So how to assess the risk? In general, this is a percutaneous injury. For HIV, the risk 0.3%, hepatitis C 2%, and hepatitis B for those who is negative for E antigen 30%, and for those who is hepatitis surface antigen positive and E antigen positive up to 50%, and for mucous membrane is less than that one. So in our area, the Dammam Medical Complex, we have over from 1424 to 1429, that's 5 years, total reported 348. From these, we have 7 from a patient who is hepatitis surface antigen positive, but I don't know really about E antigen, and 41 for hepatitis C positive, and HIV from 2, which is already AIDS, and they was hospitalized. Both of them for this one HIV, they given prophylaxis and non-converted. Just I keep it in my mind a number of 3.